The acronym is actually BACC, B-A-C-C. That stands for Biomarkers in Acute Cardiovascular Care. We had two key questions. First, is a 1 hour approach as safe as a 3 hour approach? Do we really need to wait for 3 hours before diagnosing or excluding myocardial infarction? And second, is a lower, more sensitive cutoff probably better compared to the 99th percentile of a specific assay as rule-out cutoff? First, a 1 hour approach was as safe as a 3 hour approach. We don't have to wait for 3 hours before diagnosing or excluding acute myocardial infarction. Our data was very clear in that. Second, the lower, more sensitive cutoff that was 6 nanograms per liter in that specific assay performed way better than the 99th percentile. And that resulted in higher negative predicted values, so better chance to really rule out myocardial infarction. And it also resulted in lower follow-up mortality when we applied that new and more sensitive cutoff.
We have several new important aspects of those guidelines. Number one, now we can make a diagnosis of myocardial infarction faster than previously using a high-sensitive cardiac troponin. So now the guidelines recommend as an alternative to an assessment of myocardial infarction at presentation and at 3 hours with a troponin measurement, you can even make the diagnosis faster after 1 hour of presentation. So this may be very important to diagnose also small myocardial infarction and to rule out the diagnosis in patients who have extracardiac diseases. Number two, the treatment with dual antiplatelet therapy may sometimes be shorter, sometimes be longer than 1 year, according to the bleeding risk profile and ischemic risk profile of the patient. And number three, we encourage the use of the transurethral approach for coronary angiography and PCI.
I think we should separate the routine purpose of platelet function testing and the selected use to manage complications. And we have to admit that so far, platelet function testing is not recommended as a routine tool because we are still missing data which support that we can improve outcomes in every single patient that we treat with antiplatelet agents. However, in difficult clinical scenarios, when we have some complications or patients in which we don't know how to give antiplatelet and how intensive we give antiplatelet treatment, there may be a help in case of clopidogrel, but not in case of aspirin.
In the Albatros trial, the hypothesis tested was that aldosterone blockade would prevent death, heart failure, cardiac arrhythmias in patients presenting with myocardial infarction. This is a randomized study, and we recruited patients with myocardial infarction, ST elevation or no ST elevation. We randomized these patients as early as possible, and these patients in general had no heart failure. We randomized these patients sometimes in the ambulance for aldosterone blockade with spironolactone versus no aldosterone blockade. The primary endpoint was a combination of deaths, resuscitated cardiac deaths, severe ventricular arrhythmias, need for a defibrillator, or heart failure. And this composite endpoint was not impacted by the strategy of aldosterone blockade. So the study is neutral on this endpoint, and is also neutral on all the secondary endpoints we had. Aldosterone blockade in myocardial infarction without heart failure is not associated with an improvement of clinical outcome. We may have a benefit in STEMI patients, those with ST elevation MI, but this needs to be confirmed in a new study because this is a subgroup analysis.
The study is named CIRCUS. CIRCUS stands for Does Cyclosporine Improve Clinical Outcome in STEMI Patients? It's about what we call reperfusion injury. The idea was to try in humans to see whether cyclosporine could not only reduce infarct size but also improve clinical outcome. We selected a high-risk population of ST elevation myocardial infarction patients. All the patients were anterior infarcts with a full LAD coronary artery occlusion at admission. Unfortunately, we found that cyclosporine had no effect on the primary endpoints, no effect on cardiovascular death, no effect on rehospitalization for heart failure. Reperfusion injury is an important feature that we have to consider in STEMI patients, but that cyclosporine is not the appropriate drug for today.